This is going, well, it's hard to know how interactive we can be because I want to give you a broad overview of a lot of different concepts in a short period of time. Everything we're going to be talking about could be, we could spend a lot more time on it. And I also want to point out that VCU has an HIV AIDS Education Center located in Dwight Rackley is the head of that. Dwight just came on, he's a nurse practitioner who just came on board and switched his roles recently. So the VCU HIV/AIDS Center is your resource for in-depth education and in-depth clinical education too. We've worked with them a lot over the years, and I used to work for them. So, and things have changed a lot. I started out as a nurse practitioner in the infectious disease clinic at VCU in 1993. They had a caseload of about 400 patients. I'm not making that up. And now things have definitely changed. There's a huge caseload, and they're very busy. And we in the community settings are very busy too. Folks who have HIV and do not have insurance, or they do have insurance, can access care through Capital Area Health Network. Me and Dr. Veronica Ayala Sims see patients at the locations. Crossover Health Center on Cowarden also has an HIV clinic for people who are uninsured or on Medicaid. And Daily Planet has recently gotten a grant to start providing medical care for people with HIV. They've had a grant for years to provide dental services for people with HIV, but now they also are providing clinical care. And Kara will be glad to help anybody over there. So things have changed. Back in the day, and I'm talking their 80s, early 90s, the thoughts were that patients were not going to have that long of a life expectancy. And now things have definitely changed. We have lots of medications that can be used. If someone with HIV is able to get on a medication that they can, number one, tolerate without side effects, and number two, they actually take every day to suppress their viral load, their life expectancy is the same as someone who does not have HIV. COVID, that's the hot topic. If someone with HIV is on antiviral therapy that is suppressing their viral load, they also have no greater increased chance of contracting COVID as someone who does not have HIV infection. Of course, the comorbid conditions, diabetes, hypertension, obesity, all of those things do increase their risk. But the fact that you just have HIV, if you're under care and your immune system is competent, then you're not at increased risk. So that's something that comes up a lot. I'm going to tell you, we're going to go over a few things, and I'll try to keep on time. And am I supposed to hit a button down here that says admit when somebody comes in the waiting room, Logan, or do you do that?
No, we'll take care of that.
Yeah. Okay, great. Thank you so much. So I'm not sure if we are going to do this. Okay, I'm going to try doing the slides, and hopefully this works. If it doesn't work, let me know, and we will figure it out then. So I'm doing a slide setting show. Can you see that, Justin?
No.
Oh, okay. Well, we're going to skip it.
You're going to have to hit share screen at the bottom of Zoom.
Okay, let me hit share screen at the bottom. Okay. Zoom. I am not getting, okay, I'm not getting the menu that lets me see sharing screen. So we're just not going to worry about it. Logan, what I'm going to do is email you. I have about 6 very, very basic slides with some resources on it that I will send in to you, and you can send it to the participants afterwards. Okay,
it's got some, and I can share the screen as well if you want.
Yeah, it's got clickable links, so that's good. So the things, you can't think about HIV in a vacuum. That's the most important thing. You have to think about it in the context of risks for sexually transmitted infections, and also in the context of incarceration. People who are incarcerated do have a higher risk of becoming infected with HIV. And also in mental health care, there have been quite a few studies looking at mental health problems in people living with HIV. Having depression, having addiction issues, using IV drugs can definitely increase your risk of acquiring HIV. Using drugs, alcohol that can alter your behaviors, increase your libido, decrease your inhibitions, can also increase your risk of acquiring HIV and other sexually transmitted infections. So HIV is not in a vacuum, and that's important to think about when you're thinking about looking at a population, looking at groups that you're caring for, and what's their access to healthcare, what's their access to health education, what's their access to prevention methods. So in thinking of our spectrum of taking care of people with HIV, we start with what's prevention? Prevention of sexually transmitted infections and prevention of HIV and prevention of substance abuse all complement each other. Right now in Richmond, there's a lot of syphilis that goes around. There is a lot of gonorrhea. And we are always struggling with the patient education to make sure people understand it's not just penetrative activity that you should use condoms with, but you also need to use condoms or or dental dams. There are oral latex that can come in flavors that you can use with oral contact, because you can contract sexually transmitted infections from oral contact just as well as you can from penetrative activity, from vaginal, rectal, or vaginal, from penile, rectal, or penile vaginal activities. So that education is what we really want to focus on. And I'm going to touch on this in a few minutes. We'll come back to it. But PrEP, or pre-exposure prophylaxis, giving someone who is at risk of acquiring HIV medications that we use for HIV treatment in advance, that they take every day, does decrease their risk of becoming infected with HIV. So we'll come back to PrEP in a couple minutes. Also, then how do we diagnose HIV? How do we get people in for medical care if they're young, they're healthy, they feel good, they don't think that they need medical care? There are outreach programs that reach out to test people for HIV alone. There are outreach programs that reach out to test people for HIV and sexually transmitted infections all at the same time. For folks that are very fearful of anybody knowing about a diagnosis they have, there are home test kits for HIV that are available. And in the past couple, I'm thinking about people that I've seen in the past few months who were newly diagnosed. Had one person who tested on a home test kit first, then went to an outreach clinic and got tested, had a confirmatory test, then came to us. We've had folks who went to outreach events that were held at a community group like Minority Health Consortium that's on Clay Street. They offer outreach testing. They have hours in the evening that people can walk in and get tested for gonorrhea, for chlamydia, for syphilis, and for HIV. So having that available in the community where people can easily access it is really good. Okay. Then what's the next thing we have to worry about? Okay, so we've done prevention education. We've alerted people to the need to get an HIV test and testing for other infections. If they test positive, the next important thing is, how do we do the linkage to care? Many of our clients don't have any insurance. when they first come to us. So letting them know that there are places in the community where you can go and you can get service, and you don't have to have insurance, and you're not going to get charged an arm and a leg, because we have grant funding through the state health department that comes from HRSA, Health Resource Service Administration. So that's important to know. Recently, we had a gentleman come to us who had been diagnosed about 5 years ago. He had a job at the time. He had insurance. He went to a physician at a private practice and got care for a couple years. And then he lost his job and he lost his insurance along with it. He didn't know we existed. He didn't know about the Ryan White program that is administered through HRSA, which does give funds to the states and the US territories for direct care, for medical care, for medication that provides services for people who don't have insurance. He got another job, got insurance with it recently, had gone to Patient First for care, and was going to be using them as his primary care folks, and talked to them. And the folks at Patient First who took care of him said, well, you know, you really need to call these people because they will take care of you, and you know, they can get you on the medications. They have some extra services, and they see you whether you have insurance or not. And I think back years ago when he first lost his job and lost his insurance, I think he was too embarrassed to actually even call the private physician's office. If he had called them, they know that resources exist. They can refer them to places, and we'd be glad to see you without insurance. We can use the grant funds to help provide care for you. I think he was embarrassed to ask about that. So that does exist. We have case managers, which is a luxury that we are afforded by the grant funds that private practitioners don't have funding for, because case management is not considered a reimbursable expense for many insurance programs. The case managers help with doing a psychosocial assessment. They help with connecting the patient to any financial resources they might help. So we're not just seeing people for their medical care. If they are having trouble accessing food, we can connect them with the food bank. Here at Capital Area Health Network, the person who is the coordinator for the diabetes education also has a relationship with the food bank. And the food bank truck actually comes to the Churchill location once a month, and for people to come and get groceries. If they have, the ones who take priority have a voucher from us that is administered through the diabetes education program. But then when they've all gotten their necessary supplies, it's kind of opened up to the whole community that can come by and get food. So having those kind of programs, having the access there, and having people know in the community around you that, oh, this is what they do at that building, okay? That helps. And so what we try to do, and this is kind of new, is rapid start. We try to get people, we have a connection with the health departments. We have a connection with Community Minority Health Consortium, where if somebody tests positive, the patient's told about the different clinics where they can get services, and the person who has helped with diagnosing them will actually call and help them get an appointment. It's been a little harder to get in at the VCU ID clinic because of COVID, and because of them wanting to keep down in-person visits. It's a little easier for them to get a more rapid, a fast appointment with us right now with all of COVID going on. But we coordinate back and forth, and I talk to the Bob Higginson, who's at the ID clinic, and Patricia Fulco, who's the pharmacist down there. So we talk back and forth. We try to get people with the most appropriate clinic that's close to their home, that they're going to be able to get to, and that they're going to be able to get in an appropriate time frame. So we all kind of know each other, and that's the nice thing about having the state grant funding, having the communication, having the AIDS Education Center at VCU, which kind of helps, with the communication between everybody else. So we want the linkage to care and rapid start. Now we try to get people started on medication if the patient is willing, if they're interested, and we try to get them started on something before their lab results are back. Another thing that's really important is we include a mental health evaluation. Some of our patients have mental health issues that are not addressed, that they either are not in care or they're in and out of care. And instead of working with a psychiatrist and having the appropriate medication, they may be trying to self-medicate with meth, their methamphetamine. They might be trying to self-medicate with heroin or with pills they get on the street. So getting them a mental health evaluation. And so many of the clinic, I think all of the clinics also have services of licensed clinical social workers or professional counselors or psychiatrists who are familiar with the risk and will provide services as well. And that's really important because for some of our patients, it's their mental health issues that once they get addressed, they're able to engage in care better. They're able to be more adherent. And, so that's an important concept. So we try not to leave mental health out of the equation. And engagement in care, it's one thing to start people on medication, but you don't want to give them, 3 months of medication or even 6 weeks and then say, oh, just come back any old time. People who find out they have HIV are in a state of shock sometimes. Sometimes they're not surprised. They have friends and who have HIV. They have seen how they've done with it and seen they've done okay. But for other people, they've been very private and they're really, really surprised about everything. And it takes a while to get adjusted to the idea. I want to ask if people have seen ads on television for, let's see, Descovy for PrEP is one that's going on now. That's the pre-exposure medication. Some of the medications are doing direct-to-consumer advertising. So right now, I think Dovato, which is a ViiV healthcare product, and that is a medication. And I have seen TV ads for that also. It's direct marketing. So sometimes we have people come in saying, well, can I take that medicine that's that I saw advertised on TV? Well, maybe, but maybe not. We've got to find out the best one for you, not the one that has the most money for commercials. That can sometimes complicate things. Do we have any questions so far, Logan?
Well, let's pause and see. We don't have anything in the chat. Does anyone want to unmute for a second and ask a question?
I have a question, if that's okay.
Sure.
It's about PrEP.
Okay.
Is PrEP meant to be taken on a short-term basis, or can it be taken regularly?
PrEP is meant to be taken regularly every day. However, the original studies that all this is based on was done in, a lot of the studies started in the San Francisco Health Department, like 20 years ago, they started these. So it is meant to be taken, and it's been studied in people who were taking PrEP every day. And most of the studies were done on Truvada, which is emtricitabine and tenofovir disoproxil. So, and it was taken every day. Since then, Gilead is the manufacturing company. They came out with Descovy, which is emtricitabine and tenofovir alafenamide. It's a prodrug of the tenofovir disoproxil. So the dosage is less and it gets absorbed into the bloodstream quicker, and it doesn't, Truvada, the original tenofovir disoproxil can increase your creatinine level some. The tenofovir alafenamide does not have that same effect. So they do have approval for Descovy, which is the newer form of tenofovir, being used in place of Truvada. However, there's a caution that it hasn't been studied with penile vaginal sex. So Descovy is not, the research has not been done to show that that's as effective. But yeah, it should be taken daily. However, let's talk about what people do with medicine when they get home. They don't always take things like they're supposed to. So there will be some people who infrequently have sex, and they may only take the PrEP around the time they're going to have sex. Maybe start a week ahead. If I've seen it with couples where one person is in one state, another one's in another state, and they get together about once a month. And the person's like, well, I just take my PrEP when I'm around the week I'm going to be there and seeing my partner. Has worked, but that is not how it was studied. Okay, so you do this and you educate your patients and you give them the instructions and then continue to follow up with PrEP. For patients who are on PrEP and they know, and they are with one partner and in a monogamous relationship as far as they know, and their partner with HIV is on medication that their viral load is below detection, then that is actually one of the best preventive things, is for their partner to be on medication. So answer your question, yes, they should be taking it every day. Does everybody take it exactly that way? There are some people who will do their own modification. I tell folks who are getting PrEP prescribed from me, it's easier to keep track of it if you just go ahead and take one every day, and then you don't forget.
That's really interesting. Thank you.
Okay, sure.
There are two things in chat. One is that Descovy generally has fewer ADRs than Truvada. So that's a comment. And then there's a question. Right. I know there isn't a cure, but how close are we to finding a cure?
That's another great question. Okay. The issue with HIV is that it injects its genetic material into the cell and then makes a DNA copy that then actually becomes part of the human DNA in the nucleus of the cell, in the nucleus of the CD4 cell, or cells with, so usually it's CD4s. There are other cells in the body that also HIV can hide out in, long-lived memory cells in your bloodstream. It could also be it likes to infect some cells in the central nervous system. So the problem is the HIV genetic material is actually hiding in the nucleus of the cell. How do you get medication into there? Or how do you activate those T cells if it's living in a long-lived cell? How do you activate that cell to get the HIV to sort of show itself, so you can then get to it and destroy it without destroying the human DNA in the nucleus of the cell? How do you deliver the drug there? So I know that researchers have been working on ways to get medication delivered into the cell. But that's the tricky part. And I know it's very challenging. Are we close? Well, maybe. Who would have thought we would come up with a messenger RNA vaccine so quickly. So anything can happen. You know, if you had told me back in, oh golly, I don't know, even in 2000, that we were going to be able to cure hepatitis C as well as we can now, I would have thought that was impossible. But everybody is getting cured from hepatitis C. The medicines work really well. So is HIV cure close? There's a few more little roadblocks in the way. And once it's determined there's a way to actually activate the cells to be able to find that hidden viral DNA copies, then we'll be able to do it. I'm not quite sure how close that is. So,
and there's a follow-up actually. What is the likelihood, given it's in the DNA, that it gets transmitted to an unborn child?
Okay, it has to be transmitted from the mother to the baby. Excuse me. And how it gets transmitted is through the mother's blood, exposing the child. Oh, go ahead and have a seat over here. Sorry, somebody just came in. So it's transmitted from the mother to the baby, usually during the birth process when there is blood exposure. The good news is that if the mother is on medication that has her viral load below 20 or as low as possible, the risk of transmission to the unborn child is pretty close to zero. You decrease the viral load in the mother, and you decrease the risk to the baby. Even back in the day, before there was any medication, and looking at population studies, when the first study they did using retrovir or AZT in treatment of pregnant women, the transmission rate from mother to baby was about 25%, which goes to show you how wonderful the human placenta is at keeping out infections, at keeping out pathogens. And just being on AZT alone decreased that risk to about, I want to say about 5 or 6%. So that's, and things have improved greatly since then. It's in the DNA of the infected CD4 cells. It's not in the DNA of every cell in the body. It's just in the DNA of the cells they like to infect, which are usually activated CD4 cells. So it's not in the genetic material. And that's the same thing when people are having, when folks are having kids, it's important to make sure they understand that it's not transmitted like sickle cell anemia, where it's actually part of the gene set of the parents. This is something that if the father has HIV, but the mother does not, and the father's viral load is below detection, or if they're using condoms during sex during the pregnancy, the risk of, so that you avoid a new infection in the mother during the pregnancy, the risk of transmission to the baby is going to be zero if the mom's not infected. Does that answer your question?
Yeah, she said thank you.
Okay, sure. Anytime. I want to move on. Something that you need to know, what's the difference between HIV and AIDS? Because patients like to know that. If your CD4 count has never been below 200, you do not have an AIDS diagnosis. If you've never had one of the opportunistic infections that are AIDS defining, then, and you have HIV, then you don't have an AIDS diagnosis. You just have an HIV diagnosis. And that's important for statistical reporting, is the main thing. CDC likes to have, you know, who's an AIDS case and who's an HIV case. And the worst classification you are, once you're classified as an AIDS case, you're always going to have an AIDS diagnosis, even if you're on medication and your immune system improves. So the CD4 count is your number and percentage of CD4 cells in your bloodstream. And if the CD4 count is over 200 and over 15%, then you're classified as an HIV case, not an AIDS case. And when people get on medication, their numbers go up and up and up. This morning, I saw a lady who, when she first came to us in 2006, her CD4 count was 61. So she was an AIDS case. She had oral thrush at that time. She also had, she did not have active tuberculosis, but she was positive for TB infection at that time. She's been on medication now for almost 15 years, is doing really well. Her last CD4 count was like 1,200. She's doing great. The other thing is that opportunistic infections that are AIDS defining can happen. Like I've seen somebody with a CD4 count of 600 develop a case of active tuberculosis. Long time ago, but nothing recent, fortunately. So you've got to think about those things. The most common opportunistic infections I think that folks see is the pneumocystis pneumonia. It used to be called pneumocystis carinii. So in older things, you might still see PCP pneumonia, but the organism was reclassified as pneumocystis jirovecii maybe a decade ago. So that's one. People come in, they have difficulty with breathing, they have a characteristic chest x-ray, and they can be treated for that. But that sometimes is what brings people in. Also, I've seen folks who were diagnosed and also had esophageal candidiasis. So they had a yeast infection a candida infection all down their esophagus, which had caused them to have a lot of pain with swallowing, difficulty swallowing, and maybe a severe weight loss. So that's something else. Toxoplasmosis, which is a CNS infection, and people would have terrible headaches, maybe even a seizure, and all of those can be treated. And once somebody is diagnosed and they're treated for their opportunistic infection and get on medication, their immune system can strengthen, and and those infections can be suppressed with medication. And once their immune system gets stronger, many times you don't need to take any more suppressive therapy, depending on the infection. So I'm going to share and the next thing, Logan, that I'm going to share with you that I'd like you to send people around to participants. There are a lot of resources online. One of the resources are treatment guidelines for people who are newly diagnosed. What labs do you get? How often should you see them? Which medicines should you start people on? If you have patients who have HIV, but they also have renal insufficiency, or they're on hemodialysis, or what if you have somebody who has liver compromise, then those treatment guidelines also have tables that talk about that. And if you find somebody who has one of these opportunistic infections, how do you treat them? If their immune system is very weak, what type of prophylactic medication do you give the person? How long do you give it? That's all on the treatment guidelines, which is on hivinfo.nih.gov. It's something that I refer to all the time. It's very, very helpful. And let's see, is there any way you can share that's my screen?
So do you have a green arrow at the bottom that says share screen?
I do not. No, it's not on my thing at all. Oh, well. So anyway, I'm going to be sending these around to you guys, and I will send this to Logan and she will send it to you guys. But there's some really wonderful resources I want to let you know about. So the treatment guidelines are hivinfo.nih.gov. So it's the National Institutes of Health, and the treatment guidelines are updated routinely in different sections. They're dated as to when they were last reviewed. And the treatment guidelines have everything from, the treatment guidelines for pediatrics as well as adults, guidelines for women who are pregnant, and also guidelines. These came after Hurricane Katrina decimated New Orleans, and the main research center for HIV in the city of New Orleans was under a lot of water. So there's even a treatment guideline for taking care of people after a disaster, and you don't have access to anything. What are some things you can do? How do you help them? And the priorities of getting people into care and trying to maintain their care. There's also a drug resistance database that's at hivdb-database.stanford.edu. That's another very, very helpful tool for people who are treatment experienced. You've got patients who have had HIV for 1 or 2 decades. They've been on lots of medicines. For whatever reason, they've not been able to be adherent to that medication. Maybe they went through a disaster and lost access to their meds. The drug resistance database helps determine which medications are going to be the most effective for that patient. And then CDC on their website has an HIV Nexus clinician resources. If you go to cdc.gov/HIV, and one of the resources there is going to be for clinicians, which is the other thing I wanted to talk to you about, you guys. PrEP. We talked a little bit about PrEP. It's pre-exposure prophylaxis. PrEP with Truvada was all that we had for years. Now we have PrEP with Descovy. Which one to pick? And also, how do you get it paid for? That's the important thing. Some insurances will cover it. Some patients who need it either have insurances that won't cover it, or the patient doesn't have any insurance at all. The manufacturer for that medication is very helpful. They do have patient assistance programs where the person can get a prescription from their provider, whether it's an NP, a PA, a physician. They can get a script. They can either go online or call to access this patient assistance program, and then they will be able to get it for free. And it's usually for a year at a time. For PrEP, this goes back to trying to prevent HIV. For PrEP, we get people in, test them to make sure they don't have HIV in the first place, because you don't want to give this to someone who actually has HIV. Descovy or Truvada, they're only partial treatments. It would not be a complete treatment for HIV. So you don't want to give it to somebody who actually has the virus. So testing them, getting them into tests is important. Testing their renal function is important. Testing for other STDs at the same time is important when they first come into care. Talking to them about using PrEP every day. And if you've seen, let's see, my my daughter watches RuPaul's Drag Race, and I watch it with her half the time. And they have a lot of ads for PrEP and for the HIV drugs on there. So there are other programs, other networks that I've seen ads later in the evening as well. So that's important. Also, the other thing that's important is that emtricitabine and tenofovir also have suppressive effects against hepatitis B. So testing the patients for active hepatitis B before you start them on this is important. It could very well be useful in the suppression of hepatitis B, but you would not want to stop it suddenly. Okay, and rapid start is something I talked about. And so what we try to do is have relationships with the health departments around the town, have relationships with community agencies. Minority Health Consortium is one. There's another called Nations, which is nation with a Z at the end, that also does outreach to transgender as well as anyone who's at risk for HIV and STIs. They also have a relationship with the health department where they'll provide point of care testing in an outreach setting. So we have the relationships with folks like that, and they're able to contact us if they have anybody who tests positive. Our case managers have cell phones and take turns being on call, or people can call and leave a message. So the case manager is the first point of contact. Because we are federally funded, we have funds from HRSA that promote everything. Then we do need to do financial eligibility for everybody, and our case managers do that first. And case managers are also trained in counseling people about HIV, about risk factors, about decreasing risk factors, and are very good with talking to patients about using condoms. So we get folks in, we bring them in, get their blood drawn, and talk to them about, do you want to start meds now? Or would you rather wait and come back next week when the labs are back? You know, what do you, and talk to them about, these are some of the pros of being on medication. The goal behind rapid start programs is to decrease viral loads as soon as possible in individuals so that you're decreasing your community viral load and you're decreasing the risk of transmission, the risk of new cases in your whole community. So that, and we will start them on meds, and it's all kinds of things. I've had people who at the beginning said, I don't want medicine, and then by the end of the time that we have talked to them, they say, well, I really would like to try the medication. We have samples available here from a couple of the pharmaceutical companies who are approved for, there's two that are approved for rapid start. And so I can give somebody a sample and they can walk out of here with a month's supply of meds, or a week or 2 weeks, depending on how soon we're going to need to see them back. And with the advent of telemed, that's been great because we can contact the person when their labs are back a week later or 2 weeks later, and we can do the visit by telemed. They don't have to miss work to come in. You know, it's been really good. So telemed with us has been great. The other one concept that I want to talk is to mention undetectable equals untransmittable. And as soon as, and this was, the concept came out in 2016 at the international conference. Then there was a lot of talk about, if the person's viral load is below detection, is less than 20 viral particles per cubic milliliter, then you're not going to be able to transmit this to someone else. The risk of transmission is pretty close to zero. And that's over thousands of, tens of thousands of participants in studies internationally on every continent except Antarctica. And, you know, with different kinds of medication in same-sex couples and heterosexual couples. So if the person with HIV has a below detectable viral load, the risk of transmission to somebody else is pretty close to zero. So that's what is behind our rapid start, getting people into care as soon as possible after diagnosis, using different strategies to engage them in care. And those strategies vary depending on your population. and where you're at in town. There may be folks who come back and see us because they know that we're going to be able to give them a bag of groceries. If I know that they're having issues with food in advance, me or the case managers, we can talk to our liaison with the food bank and he can have groceries ready for them. So that sometimes is just enough to get somebody to come back for their appointment where they wouldn't otherwise want to come. So it is 12:50. We need to call an end to this. So any other questions or anything, Logan? I can hang around for a little bit longer.